What an amazing way to begin today, this terrific Tuesday at our inaugural USVI Cancer Summit. I am Dr. Linya Fredericks, the Territorial Chronic Disease Director at the Virgin Islands Department of Health. I'm now going to welcome Dr. Nicole Cregwell-Sims, who will bless us in prayer.
Thank you so much. Good morning, everyone. Before I begin, our commissioner, Husteng Kanasyong, actually gave me some words to read, which I thought are very, very powerful. And it actually is titled, Powerful Cancer Quotes. There's always hope beyond what you see. It's possible not just to survive, but to thrive and to live a healthy, wonderful life again. Life is 10% what happens to us and 90% how we react to it, which we all know, right? If we could just center ourselves for a moment and bring ourselves into this room. Father God, we want to thank you this morning for bringing us together, like-minded people with hope, like-minded people with a sense of caring and purpose around this topic. Lord God, over the next 2 days, we're asking that you bless us and guide us and watch over us as we discuss, as we share, as we enlighten one another. And as we think about persons that we know ourselves as survivors, individuals in our family and our friends, we pray, Lord God, that we uncover new channels of hope, new channels of existence that will take us and propel us, Father God, into new channels of healing, new channels of love and support. We thank you, Lord God, for the team that has brought us here today and put this on. And we pray, Father, that each one of us takes away something that just has a domino effect and touches the lives throughout our community. Father God, we place all of this in your hands, and we ask today that through love, unity, and support in this room and beyond, this summit is a true success. In your name, amen.
Thank you, Dr. Sims. And Dr. Sims is our Assistant Commissioner at the Virgin Islands Department of Health. So I would officially like to welcome all of you, both of you on the live stream and those of you in person with us today. Thank you for taking the time out of your busy schedules to join us. In person, we have representatives from Senators Novell Francis' office and Senators Ray Fonseca's office. We have our Health Commissioner, Husteng Kanasyong, her executive leadership team. We have Department of Health staff as well, key Department of Health staff, for without them, this could not be possible. We also have representation from the USVI Cancer Coalition. We have representation from other government agencies, the Office of Health Information Technology, the Department of Human Services, the Health Insurance Board, and the Office of the Governor. We also have the USVI Cancer Coalition present, the American Cancer Society. People flew in all the way from Puerto Rico and Miami to be here with us today. We have representation from Puerto Rico's Comprehensive Cancer Control Program. We have representation from local hospitals, physicians, and nonprofit organizations. And we have two special ladies here with us from Strategic Health Concepts, which they will be introduced later. They will be facilitating this entire process. So how did we get here? About a year ago, the Department of Health secured funding through the CDC for the National Comprehensive Cancer Control Program. This program aims to support cancer coalitions in the implementation of cancer control plans. Over the next 2 days, we will spend time disseminating information to you and getting feedback and input from you all on what should go in this USVI cancer control plan. I would be remiss if I did not recognize our extraordinary partners from the USVI Cancer Coalition. They have helped to make this summit possible. These ladies had the foresight to start the USVI Coalition 2 years ago, even before we got the funding. They built the foundation. Now with the federal funding, we're able to expand the scope and expand the coalition and restructure it. I really want to say thank you all from the USVI Cancer Coalition for allowing the Department of Health to work alongside you. So our theme for today is improving cancer care through equity and innovation. Cancer is a complex disease. It is very often difficult to prevent and treat, resulting in most people being affected by cancer. We must be innovative in our approach. The tagline for this summit is, "I'm winning this for us." I resonate with this on so many levels. Cancer is very personal to me, so I would love if you allow me to share my personal story. I lost my 4 grandparents to cancer. 2 of them died before I was born, and the other 2 before I was the age of 22, so it runs deep in my family. Being in a public health field now as a grown-up, I often wonder how the social determinants of health affected their outcomes. These social determinants of health include our geographic location, access to screening and prevention and treatment, and education on the importance of prevention and screening. These are some of the strategies that will be included in our USVI Cancer Plan to focus on equity. In closing, this summit is just the beginning of a concerted effort to address the burden of cancer in the territory. The work doesn't end tomorrow when you all go back to your busy lives. We will need your continued support and input as we draft and implement the USVI Cancer Plan. Again, thank you all for showing up, and I look forward to a harmonious working relationship with you all. So I will now like to introduce my immediate supervisor, Dr. Janice Valmon, to give opening remarks. Dr. Valmon has worked in the public health sector for over 25 years. She is the Deputy Commissioner for Health Promotion and Disease Prevention at the Virgin Islands Department of Health. She completed a health assessment in 2020 and developed a community health improvement plan called Healthy Virgin Islands 2030 in 2021. She values community engagement and volunteering on local boards and work groups. Dr. Valmon.
Good morning, good morning. Let me add my welcome to Linnea's today. And here as the Deputy Commissioner for Health Promotion and Disease Prevention at the Department of Health, I'm inspired by the directors who I have the honor and pleasure of supervising or working with. They know I don't use that word a lot, right? So we are a team, and I appreciate the opportunities to always participate in these types of activities. So Linnea stopped off by talking about the importance of addressing the chronic disease burden and the fact that one of the things I'm very, very proud of in my work at the department with Commissioner Nkansong's guidance and the amazing support of Dr. Donna Christensen and others in the Department of Health was working on our community health assessment, which led to development of a community health improvement plan, which we called Healthy Virgin Islands 2030. So very often, plans sit on shelves. Not so in Tita's Department of Health. Plans do not sit on shelves. So I just want you to share that thanks to the viewing audience and the huge Virgin Islands community that came out and supported our community health assessment to help us select the priorities that we want to address through 2030. Guess what? One of those priorities were, in fact, priority number 2 was a chronic disease burden. As part of that work, we are able to, working with the data from the needs assessment, working with input from the community, even in COVID, we were very proud to have over 500 persons respond to a survey, a needs assessment survey. That was huge. So VI community, we thank you for that. The chronic disease burden addresses 2 or 3 goals. So we talk about preventing the chronic disease burden in children and adolescents. We talk about preventing the chronic disease burden among adults. And goal 2.3 specifically speaks to preventing the chronic disease burden associated and reducing mortality associated with cancer. So 2 of the cancers that bubbled up as a priority, clearly all cancers are important, are prostate cancer and breast cancer. And guess what? That is what our data is telling us. From the cancer registry data, the top 2 cancers that affect the population in the Virgin Islands are breast cancer and prostate cancer. So I just wanted to bring us back full circle to why we are here today. I had the pleasure of working with Linnea on developing the grant application. That took some work. And we also, as part of that grant, we also received the funding for breast and cervical cancer early detection screening. Again, the CDC and the entire public health field, we are making the connections, looking to address all the social determinants of health, not just the disease, just focus on the disease, but what are some of the causes. So the cancer control plan that we hope to develop as part of this process is a huge step in the right direction to help us achieve those goals and objectives that we set up for ourselves to address as a community, not just the Department of Health. Because Linnea talked about all the partners who are here. Guess what? We cannot do this without you, internally and externally. So I just want to close by saying thank you, thank you, thank you for being here. Thank you for your commitment for over the next 2 days to help us develop this plan. And if it has anything to do with it, this is not the last time you'll hear about this. We will be working on this until we can see some results. So towards Healthy Virgin Islands 2030, I want to thank you for your commitment, for your contributions already, and look forward to an amazing 2 days. Thank you. So at this time, I have the honor, I called her name so many times, I have the honor of introducing my commissioner, our commissioner of health, Justa Tita Encarnacion. So Justa is a native Virgin Islander who started her healthcare career as a pediatric nurse in St. Croix. Oh, by the way, that's another major priority, right? The health of children in the territory, where she developed her clinical assessment skills and compassion for patients and families. She has acquired an associate and a bachelor's degree in nursing, a master's degree in business administration, and healthcare management certification. She went from practice administrator to commissioner of the Department of Health, using her leadership and dedication to improve healthcare in the Virgin Islands. Commissioner Encarnacion.
Thank you so much, Dr. Valman, as well as you, Dr. Fredericks, and welcome to each and every one of you. This is awesome. We have individuals in this room from all over, from Puerto Rico, our neighboring island, and from the nation as well, from other jurisdictions. It is truly awesome to be able to stand here today. Of course, I will begin by adding to the recognition. Dr. Valman, of course, worked on both the CHA, the Community Health Assessment, the Community Health Improvement Plan, and of course, that developed into our Department of Health Strategic Plan. And she had a partner in crime in that as well, and that is our awesome former delegate to Congress, Donna Christensen. So she's also here with us today to add to that plan, and so I just really wanted to recognize that. That couldn't have happened without each and every one of you, because we had hospitals, we had federally qualified health centers, we had community health workers partnering with us to complete that plan as well. A big believer in collaboration, commitment, and consistency. And I always say, if you're not consistent, you're not going to really succeed. You have to show some consistency in what you do and the fortitude. But we have a wonderful group of individuals in the Department of Health that present ideas, that actually put those ideas into work. And of course, yes, we are going to be back, because one of the things that Dr. Frederick spoke about is that equity is one of the things that we're focusing on as we actually sit together and build a plan. So guess what the next plan we're going to be working on? Dr. Janice Belmont, don't laugh. I hear you laughing, but you're going to be leading this. And that is the Health Equity Plan of the United States Virgin Islands. So that's one of the things that we'll be working on next. I'm also interested, and I speak about this over the last few months more so than anything else, is data. How are we collecting our data, especially for cancer, as well as so many other things? You know, Dr. Frederick spoke about the fact that cancer has touched her in her life. I don't think that there are many of us that can say we haven't been touched by cancer, whether it be a loved one, you know, a very close family member. Each and every one of us, for some reason, has been able to say that they've touched cancer. And before I go on, we have a very special group of individuals within this meeting setting as well, and those are our survivors. So I would like to take the time to recognize our survivors and ask them to stand, and please give them a round of applause. Please stand. And it is really and truly because of you. Being able to beat this is why we're here. We have to make sure that we put into our plan preventive measures. Dr. Van Baan speaks about me, but I'm going to speak about her. One of the things that she always says is, one, you can't be sitting more than 30 minutes, right? You have to stand, you have to drink a lot of water, and you have to eat right. So those are the kind of things that we'll be speaking about today, but how do we actually implement them? So I'm a big believer in let's see what the outcome is. And I know I'm now going to speak to you, the general audience, who are looking at us. Don't be afraid to type in your requests, to type in what you think we're saying, because you're going to be listening to us. So this is a working meeting. So while we are speaking, I want you to go on and say, you know what, Commissioner, Dr. Fredericks, I hear what you're saying, but I think you should be doing this a different way. But be kind to us, okay? Use kind words. But really and truly give us some ideas from your perspective as what we could be doing differently, because this is a plan that's not just for everyone in this room. This is a plan for everyone who lives today in the Virgin Islands and who will be living in the Virgin Islands 2 years to come. So this is something that we're developing today, but it's going to last us a lifetime as well until it's going to be changing, yes. But we want to make a really strong plan come out of what we're looking at by the end of tomorrow. And of course, we're going to be revamping it in several months. As you indicated, we will be speaking about that as well. And Nikki is here with us from CDC. And so I'm sure you'll be hearing from her in reference to that. CDC is actually one of our main federal funders, not just for chronic disease, but for so many other things. And so we welcome having someone from CDC here as well. I could go ahead and talk, but before I go ahead and talk, this is what I want you guys to do. I want you all to stand up. We could put some calypso on. You laughing? No, we won't put calypso on. I just really stretch a little bit, because we're going to be sitting down, but we're going to be talking, we're going to be walking around. So you guys could do that at home too, I'm looking at you. You could do that at home too. Stretch a little bit, because when you're stretching, you're actually getting your blood going, and what's going to happen, right? Your brain is going to be going, so we're going to be thinking a lot, all right? I wish for us to put our heads together. I want to hear different opinions, because to me, that's the only way we can grow. You can sit down now. And then come up with some really fabulous ideas. So really, by the end of this, we're going to be giving Dr. Fredericks a whole lot of work to do. So that's the goal, okay? Give her we won't just leave her in the lurch. We're gonna help her. So Dr. Fredericks, thank you, and your leadership for putting this together. You and your team. Appreciate the day. Appreciate all of you. Thank you.
Thank you, Commissioner, for those inspiring words. So some housekeeping items that I forgot to mention. Restrooms are directly outside. Please take care of your needs as you wish. And remember to get up and stand and move around if you feel you need to do so. So we're going to shift gears a little bit and now go into the meat of why we are here today. With that, I'm going to introduce Ms. Karen Homan. She is the co-owner of Strategic Health Concepts, a public health consulting company. She has worked extensively in national, regional, and community strategic health planning, with an emphasis in creating and maintaining effective health-related partnerships, developing and implementing organizational and multi-sector strategic plans. Strategic Health Concepts has been privileged to support the Comprehensive Cancer Control National Partnership and CDC's national cancer programs for over the past 20 years. Strategic Health Concepts has worked with nearly all CDC Comprehensive Cancer Control funded states, tribes, territories, and Pacific Island jurisdiction programs and their coalitions. Let's welcome Ms. Karen Homan, who will be giving us an overview of the agenda and what we'll be engaging in over the next 2 days.
Thank you. Hi, everyone. Thank you for coming for the next 2 days. Hopefully you all are going to be staying here for a full 2 days. We're really excited that you all are here. You represent a lot of diverse backgrounds and perspectives across the USVI. Whoops, I don't know if that's me. Probably is me. Okay. And I don't do very well standing still behind a podium. But we are going to have a great couple days. They're full days. We have a lot of different kinds of activities. We're going to hear some presentations, learn about what's happening in the Virgin Islands. We are going to break into small groups, which you already are. We may do a little mixing up and have you have opportunities to share your perspectives and your knowledge. And all together, at the end of the 2 days, we're going to come together and we're going to have the beginning of an idea of what a strategic plan for cancer control looks like in USVI. We always say the process of doing and developing a plan is much more, or is just as important as the product. So yes, we do want a product, we do want a plan, we want a very realistic, implementable plan that's data-driven as well as stakeholder-driven. But the next 2 days for you to be forming these relationships and learning from other people and sharing your thoughts and experiences with others is just important. That process is just important as what we come up with in our hands. So we're thrilled to be here. We have, today we're going to hear about data, and we're going to hear from CDC about the national program for comprehensive cancer control. We'll find out a little bit about the data that we have here for the USVI. Then we'll look at that data and say, what does that say about us? Where are our strengths? Where are our challenges? What should be in the cancer plan? What issues do we really want to tackle? Tomorrow, we're really going to be focusing on how do we work together? What does the coalition look like right now? Can there be ways that we want to enhance that or structure it in ways that we can develop the plan in a more productive manner and especially implement the plan efficiently? So at the end of 2 days, you're going to be exhausted, but hopefully we'll have a little fun as we go along. And with that, we look forward to working with you all. Back to you, Leah.
Thank you, Karen. Okay, as we proceed with our agenda, next we will have a presentation by Nikki Hayes. Nikki Hayes has been with the CDC's Division of Cancer Prevention and Control in the agency's National Center for Chronic Disease Prevention and Health Promotion since 2002. Before joining CDC, she was a biologist in the National Institute of Dental and Craniofacial Research at the National Institutes of Health, where she established and managed the Institute's DNA sequencing core facility for more than 10 years. Nikki is currently the chief of the Division of Cancer Prevention and Control at the Comprehensive Cancer Control Branch and is responsible for the successful implementation of one of the agency's flagship multi-million-dollar cancer prevention and control programs, the National Comprehensive Cancer Control Program. Let's welcome Nikki Hayes to give a presentation of an overview of the National Comprehensive Cancer Control Program.
Thank you, and thank you for the invitation to be here. This is my first time on the island, and it's absolutely beautiful, and so I thank you for the invitation. Do we have slides? There's me, okay. So I wanted to talk to you today about the National Comprehensive Cancer Control Program and just give you an idea of what we envisioned 30 years ago when we created the program. We are celebrating our 30th anniversary in September, and so we look forward to having you there with us. And I just wanted to share what we were thinking then and how we've progressed over the years and where we are today. And I appreciate the title because this really is about planning, it's about partnerships, and it's about creating policy, big P and small P changes. Next slide, please. So at the CDC, our role in cancer prevention and control is to really provide leadership so that we can help to enhance public health programs and we can enhance the way that we approach addressing cancer issues. We do that through monitoring and surveillance, and so you know about that through our cancer registry program. We also have other ways that we are collecting data and using that data to really tell the story about cancer and how it affects and impacts our communities. We do that through these policy systems and environmental change approaches to prevention and control. We know that we can have a much larger impact when we are looking at how we can control these issues from a broader perspective than trying to do one-on-one interventions. Really looking at underserved and disadvantaged populations and communities and how we can invest in not only the research but also the programmatic interventions to really help make a difference in these communities. really working to expand our opportunities to increase awareness among our communities, outreach in our communities so that people understand the burden and that we can work together to address it. Also looking at how we can support clinical preventive services, how we can support the implementation of those services everywhere, not just in communities that are really, really rich in resources. Working to improve the public health infrastructure so that we can support these programs across the board all the time. What we learned during COVID is one of the silver linings, I think, of that horrible experience is that the public health systems and public health infrastructure really is absolutely critical to the health of our country. And so really working to support in the ways that we can, the public health infrastructure is a priority for us. And then working to improve the quality of life for cancer survivors. And you'll hear me say that many times throughout this presentation. Next slide, please. So our framework really is around the idea and the premise that all people can live free from cancer. And the way that we make that happen is that we work to reduce preventable cancers, that we work to make sure that people can get the right screening at the right time, and that we work to make sure that our cancer survivors can live longer, healthier lives. And we do that through our framework that you'll see on the next slide, which I think really does, it mirrors exactly what you're doing here. So next slide, please. Again, we're working to prevent cancer. We're working to make sure that everybody can get screened when they should get screened. We're working to make sure that cancer survivors can live longer, healthier lives. And we're doing that by reducing risk. We're doing that by scaling up best practices so that we can see increases in screenings. And then we're working to improve the health and well-being. We think that it's important to do that by looking at equity and making sure that everybody has an opportunity to reduce their risk, that everybody has an opportunity to get screened, that everybody has an opportunity to live well. We begin with the end in mind, and so I appreciate this planning opportunity because there is nothing worse than saying, oh, we're gonna go out and do this, and then just really not know where we're going or how we want to get there and what we want to get to. So beginning with the end in mind is important. Collaboration is absolutely critical. When we started the program 30 years ago, it was all because we recognized that there were a lot of things going on in cancer prevention and control, but they were going on in silos. And so what we decided when we put this program together with our colleagues at the American Cancer Society, our colleagues at the National Cancer Institute, and others were that if we all work together, then we can bring our little pieces together and we can create these much larger pieces and have a much greater impact. And we have to be very deliberate and intentional in what we say, how we say it, when we say it, and where we say it. I think that what we bring to the table at CDC is we can bring the data, we can bring assistance with translation and evaluation, and then partnerships. We can absolutely help to garner partnerships. We can help to create relationships that are really critical to this work. Next slide. Some more about the national program. Right now, we currently fund all 50 states, DC, 8 territories, and Pacific Island jurisdictions, and I'm so happy to say that the USVI is one of our awardees. And then we also fund tribes and tribal organizations. And we really do focus on risk reduction, early detection, making sure that we can help people get access to better treatment options, improve the quality of life for cancer survivors, and we absolutely have to advance equity and cancer health outcomes. Next slide. So we do that through this coalition-based approach. And what that means is that we know we can't do it by ourselves. What that means is that we have to have a diverse group of stakeholders in the room to have these discussions, to talk about what we need, how we need to do it. This really all centered in, what the things that we all prioritize and how we can make sure that we can bring all of that together. And it's volunteers. So I do want to say one thing, that as we go through this work, let's always remember that our Cancer Coalition members are dedicated volunteers who have day jobs, and we need to be able to support them in that work. But we are absolutely extremely appreciative of what the coalitions and the coalition members bring to the table. And so as we've done recent analysis of who are on the coalitions, what we see is absolutely public health workers. But we also see representation from colleges and universities. We also see representations from community groups and community networks, especially faith-based organizations, We also see members from professional associations, and so we have nursing associations represented, we have oncology represented, we have primary care associations represented, and as I've heard about the people who are in the room today, I was like, oh, you guys are already on it. So I appreciate the work that you're doing. People coming together from local businesses, people coming together from places where decisions are made, local government, state government, national government, and then also looking at people who can create, who can make policy, who are represented on coalitions. And I think all of this is important so that we can make sure that not only is the plan that we create representative, but the plan that we create is also has buy-in, and it has folks who are really invested in it and invested in implementing the plan. So the next slide, please. We fund the National Comprehensive Cancer Control Program through one cooperative agreement that funds the National Breast and Cervical Early Detection Program, the National Program for Cancer Registries, and the National Comprehensive Cancer Control Program, all in one funding stream. It's extremely difficult, it's hard to do, it's a beast to respond to, but it is the way that we want to make sure that all of this work is seen as collaborative work. And so we are really working to support breast and cervical cancer screening, which we hope will also, and you'll see that a little bit later in a couple of the slides, also influence other cancer screenings, working to implement a cancer control plan that everybody can buy into, and then using the surveillance programs to really report and monitor cancer burden. It has to be, it's a collaborative approach, it's intentionally collaborative, because we really do have to do this in a comprehensive and a coordinated way in order for us to advance goals around health equity and in order for us to really make a difference. Next slide, please. So, what do we have to do? All three programs, and then I want to extend that and say even other chronic disease programs are responsible for creating these cancer plans and implementing these plans, because we see the needs of all of these areas in the plan. So it's all about leveraging resources, it's all about making sure that it's representative, and we're working together to get that done. So I want to go through a couple of the strategies for the national program, and you'll see in each of the strategies where we have opportunities in comprehensive cancer control to influence the development of goals in those areas, and then to also influence the change that we want to bring about. The next slide, please. So the first strategy is around enhancing the National Program for Cancer Registries. And so one of the responsibilities of the National Comprehensive Cancer Control Program is to really help to support the registry program. And what we mean by supporting the registry program, we mean by supporting the registry program because we're working together to not only make sure that the data is available, but we're also working to make sure that our community understands what the data is telling us, especially our decision makers, especially the people who are living in the community who really need to have an understanding about how cancer is affecting us, and really making sure that our decision makers really have an understanding of how cancer is affecting the people and the places where we live. And so one of the things that we are asking the cancer coalitions to do and the comprehensive cancer control programs to do are to work with the registries to identify the top cancers in your community, to understand where the disparities are, and then to really work with the coalition leadership to make sure that not only are we addressing, do we know that information, but we know that information because we can address that information because we know it. And so cancer registry representation on the coalition is important. Next slide. And this is just a promo for our National Program for Cancer Registries. Next slide, please. The next thing that I want to talk about is surveillance through other systems as well. And so your community health needs assessment is absolutely critical to the work that we want to do around cancer control planning. Even crowdsourcing, web scraping data, any data that you can come across that represents the impact of cancer on your community is absolutely important, and we ought to be considering it in the way that we are looking at our plan and the way that we are implementing our plan. The next slide, please. This next strategy is around partnerships, and this is absolutely what the Comprehensive Cancer Control Program is responsible for all three programs. And it really is working around managing these coalitions, making sure, as I've said before, that we have all the right people in the room and that it's representative of the community that we serve, and then really working to support the coalition. And so we've even asked each of our national cancer programs to make sure that there's dedicated staffing so that we can support the needs of the coalition, we can support the direction of the coalition, we can support the work that the coalitions are doing. And then, as I said, the coalitions need to be extremely representative of the community, and I think you all have done a wonderful job by the representation here in the room today. The next slide. And I say all of that because partnerships are absolutely critical. So partnerships from local hospitals, which we have, partnerships with insurance agencies, which we have, partnerships with other chronic disease programs, which we have. All of that is absolutely important because you can't really see it, but we'll make sure you get the slides, and then so you can access the success stories. But when we're looking across the national program, when we see successes because we have worked together in partnerships outside of the Department of Health to really make a difference. And that looks like making sure that there are complete streets in Louisiana. That looks like making sure that we're working with our Department of Education so that we can implement HPV vaccination screenings in schools. That looks like working with our schools, our preschools, so that we can educate parents about the impact or the effect that secondhand exposure to secondhand smoke has on their children, especially around asthma. So we're not just talking about lung cancer prevention, we're talking about even the way that smoking affects our children. And so these are just some ways that the cancer control programs across the country have really worked in partnerships, some of them non-traditional partnerships, to really influence what our communities have access to and what the communities are doing. Next slide. So when you start talking about, well, how do we create, what are we doing in our coalitions and how do we make sure that what we're doing is sustainable? And a part of that is always making sure that we are following the 9 habits of successful coalitions. It's a very old CCC National Partnership resource that has been edited and re-edited and revised over time. But the 9 habits have remained true. And so I really do suggest, and I know that Karen and Leslie will be addressing this, but this guide is like the holy grail for making sure that your partnerships are viable, that they're sustainable, and I really do recommend that you continue to use this resource. The next slide. I also want to encourage you to participate in our CCC National Partnership Priority Work Group webinars and all of the other resources that we provide through the national partnerships. One of them is Sustaining Effective CCC Coalitions. We have webinars that we host. We have opportunities for peer-to-peer discussions and leadership discussions that we host. And I really do want to encourage you to engage in that. One, because it gives you an opportunity to see what others are doing, to experience, to learn that for others are experiencing the same pain and pressure points that you might experience as coalitions, and really to work together to talk about how we address those things so that we can continue to move forward. Next slide. As we talk about CCC plans, I just want everyone in the room to remember and to always keep top of mind that the plan should be data-driven and they should be evidence-based, that they should represent what you need in the community, and they should also represent the resources that you have available to you to make a difference in that space. They should be created by a diverse group of partners, as we see, and they really should express the priorities, and then we ought to make sure that people understand the rationale behind how we landed on those priorities so that people can really buy into what the plan is and how we can all contribute to it. And it should be a blueprint for action. And so as we've already said, it's not a plan that will sit on a shelf, but it's a plan that everyone can see their role in, everyone can see that they have an opportunity to participate in, and everyone can see that they have an opportunity to benefit from. And so if you follow these principles as you create your plans, I think you'll be well on the way. Next slide. And then again, if you need resources around how to create plan, we have through the CCC National Partnership a series of tip sheets that help you to kind of guide your thinking around creating objectives in specific areas. And so we have tip sheets around HPV vaccination, around tobacco control, around colorectal cancer screening, how we address risk factors for cancer survivors, improving health equity, and we're always working to develop more resources, but I do want to encourage you to be sure to use these tips as resources because they have been extremely helpful to others as well. Next slide. And then as you get your plan together and you start wanting to implement the plan, we don't want to think that once we have the plan together, we're done. Because now is the really hard part. It's around, well, how do we make it happen? Because we know that cancer control plans are really here to address a very big issue and a very big problem. The beauty and the wonderful thing of all of this is that you all are here and you're committed to doing that and to working in that space together. And so it's all about how we mobilize. Even after we get the plan together, mobilize teams around each of the objective areas, creating a plan of action around how we address that objective and how we carry out the activities or the strategies that we plan. Making sure that in all of the work that we're doing around cancer planning and cancer plan implementation, that people in the community know what we're doing, that they buy into what we're doing so that they can continue to support the work that we're doing. And then we have to track. So as we're making progress, as we are counting our small wins, we need to track those wins. We need to talk about those wins so that everyone knows that this is really working. Step by step, it's really working. Next slide. The fourth strategy for the national program overall is around delivering, screening, and implementing evidence-based interventions. And so one, it's around primary prevention. So it is doing things like working with your immunization services divisions around vaccinations and making sure that we can look at, well, what can we do in liver cancer prevention and what can we do around HPV related cancer prevention, and then making sure that these organizations also know that we can work together in this joint effort to address not only cancer prevention and control, but other areas and issues as well. It's working with physical activity and nutrition folks so that we can increase physical activity, we can decrease obesity, and then that way we can reduce the risk for cancer. It's also working with the breast and cervical programs and others around making sure that there's access to cancer control screenings, to preventive screenings, making sure that we're following the recommended screening schedules, and that we're making sure that we understand where the barriers are to screening and we're addressing those structural barriers so that people can get into screening. And then again, recognizing the health and the well-being and supporting the health and well-being of cancer survivors. And I want to say thank you to all of the survivors in the room. I spoke at our church recently, and one of the things that I said around cancer is in my family, and we have been extremely, we too have been affected by cancer in many ways. And a lot of the times when I think I see people give up, I think I see people give up because they don't see anyone who looks like them, who have experienced what they have experienced and survived. So I thank you, survivors, for being here. I thank you for your willingness to tell your story, because that's extremely important to others, because when others see you rejoicing and when others see you doing what you do again, then they have hope in their situation as well. And so I thank you for that. And again, just talk about how I want to say, how reiterate how the CDC really is committed to making sure that we're doing all we can do to improve the health and well-being of cancer survivors. Next slide. I did want to share a couple of the ways that once we see the cancer plans, once we see the plans being implemented, once we see the implementation being reported through the Comprehensive Cancer Control Program activities, what does it look like? Well, it looks like activities that are reducing client out-of-pocket cost. So that we can increase tobacco use. I mean, not tobacco use, tobacco cessation use, not tobacco use. It looks like working with hospital systems so that we have these really nice and improved client reminder recall systems so that people are coming back into screening when they need screening, coming back for booster vaccines when they need that. It looks like provider education around tobacco use. It looks like working with others in our community so that we can increase access to healthy food options. It looks like working in our schools to make sure that we have increased access to HPV vaccines. It looks like working to ban smoking and then have smoking restrictions in certain areas so that we can reduce exposure to secondhand smoke. Next slide. Relative to screening, it looks like doing one-on-one education to increase demand for screening. It looks like group education around screening. It looks like doing things to reduce the structural barriers to screening, whether that's adjusting clinic hours, whether that's providing gas incentives and whatnot. It looks like provider assessment and feedback so that providers can increase their timely delivery of screening services. And it looks like all these efforts to reduce out-of-pocket costs, especially particularly around colorectal cancer screening and making sure that if you have a FIT test that you can do the follow-up colonoscopy and not get a bill for that continued screening. Next slide, please. And so relative to screening, we do have a new resource that's available from CDC around breast, cervical, and colorectal cancer screening. I would highly encourage you to take a look at this resource. This resource is for providers, but it gives providers opportunities to see what are the tools and resources that they might be able to use to get their clients, get their patients into their offices so that they can be screened. We created this not long after the pandemic, and it was really a part of how we get people back into screening, but it's a great resource for providers, and so I encourage you to take a look at this as well. Next slide. What does CCC look like when we talk about cancer survivorship? It looks like educating healthcare providers so that providers understand what cancer survivor issues are after diagnosis, after treatment, and so that they can work together to make sure that there's a better understanding of the longer-term impact of treatment and how we ought to address those issues. It looks like educating the public that cancer is a chronic disease, that it's a survivable disease, and that these are the ways that we can do that. It looks like promoting patient navigation for case management programs and really making sure that people understand the value of that service. It looks like providing information to not only cancer survivors, but providers and their caregivers so that we can all work together to address the needs, and really making sure that we are establishing guidelines so that they're to support quality and timely service. And so these are some of the things that some of our programs have been doing, and I want to encourage you to continue to think about these things as well. Next slide. These are just a couple of examples of what we've seen, some of the work that we've seen in our programs. You know, once you pull the words off the plan paper, this is what it actually looks like. And so we have ways of increasing social and small media awareness through social and small media, partnering with organizations like the American Lung Association, so you can do small events where you can actually have mobile screening. And these first couple of examples are around lung cancer, and I included that because I really want to make sure that we understand that even though the CDC doesn't necessarily pay or support a lung cancer screening program, there are ways for us to work together in the community to address one of the leading burdens of cancer, using patient reminders to encourage folks to get screened for lung cancer. Next slide is an example of working with the Department of Education so that we can make sure that people understand what cancer is, how we can get screened, and this again is lung cancer, but it's an opportunity for us to really show how we don't do this by ourselves. It's all through partnerships. The next slide. This slide shows us again partnering in communities to bring people into, and this is some work that the CCC program and the breast and cervical programs have done together to make sure that women can get into screening. Next slide. And then also working around colorectal cancer screening and working with FQHCs to show ways that we can reach into this community using patient navigators to make a difference and increase screening in our centers. Next slide. So as you develop your cancer control plans, you know, I want to encourage you to make sure that you are developing SMART-T objectives. And so I really appreciate the attention to health equity that you all are focusing. And so as you are creating your plans, we do, again, want to reiterate and let you know that we support you in this effort. So not only are the objectives in your plan SMART and measurable and achievable and realistic and time-bound, but they also are inclusive. And so they are inclusive, and we're making sure that we're giving people in our communities the opportunity to be a part of the conversations so that people feel empowered and that the work that they're doing and that their thoughts really do matter and that they are important and that they are included. And then also to make sure that they're equitable. So to make sure that the work that we're doing is centered in fairness And we think that that's extremely important, and that's the way that we're going to be able to move forward in making a difference with reducing the inequities that we see in health. Next slide. And the last strategy is around program monitoring and evaluation. If you don't tell the story, like my sister always says, well, if you don't put the picture on Facebook, it didn't happen. So if we don't look at the data, if we don't do an assessment, if we don't tell the story about what we're doing, if we don't do that in reports, if we don't do that through our success stories, then did it happen? Yeah, it did, but we got to really tell the story so that people understand that it happened and that we can continue to support this work. Next slide. And we're here to support you. We're here at CDC, so we have SMEs at CDC that will help you. We have national partners that are absolutely committed to comprehensive cancer control, and we want you to know that you can call on us at any time because we are available. Next slide. And I mentioned before at the beginning that I would not ever make a presentation about CCC without talking about the CCC national partners. The CCC national partners have been at the table from the very beginning because what we try to emulate at the national level is exactly what you're doing at the coalition level, at your coalition level. Next slide. And so we are committed to making sure that we can help support coalition efforts around creating plans and implementing plans. We started in '94 with just 5 organizations. There are 18 of us now, and we really are committed to working together to help to support you. Next slide. I think this is the last slide. Okay, y'all had me nervous. I did this because I was like, wow, they really are on time, like to the minute. So I got finished. I'm happy to take, I think I have time for 1 or 2 questions if you have questions. Yes.
Thank you, Nikki. That was a wonderful, wonderful summary. And I am Ty, from everyone who doesn't know, the medical director for the Department of Health. So, I'm sitting here. I know there were no questions, so I just thought to, use this opportunity to just bring up something that I don't necessarily know that there's an answer for. But every time we're always focusing on health equity, and I always just sitting here with my patients in mind, and thinking about a lot of the barriers and challenges that we've overcome. I'm an infectious disease physician, so I primarily see individuals for primary care with infections, all right? Okay, so I primarily take care of HIV patients living with HIV, and I'm always trying to get them for all of their cancer screenings, right? And it's one thing to actually get them to understand and buy into some of the screening, because I try to get them to do almost everything from A to Z. So once I've gotten them, taking their HIV medications, I'm like, great, right? 100%. That's the first goal. And then I'm like, okay, so now we have to take care of your diabetes. Now we have to take care of your blood pressure. Now we have to do these cancer screenings. And again, on top of all the other things, I try to make them, do like vaccines and everything. So then we get to cancer screening, and then there are many different things that some are very easy, and then some always includes the procedures. So again, we've prided ourselves on all of the victories that we've gotten with HIV management, and I'm proud to say that, especially here in the USVI, there is no barrier to treatment for getting medications, right? Anyone with any payer situation will get access to care without a problem. So I'm very proud of that. But I can't say that for cancer screening. Not even, I'm talking even just for screening, and definitely not for treatment. So although the goal is to try to ensure that everyone has the opportunity to be cancer-free, that's not really the reality. And I was listening, and I'm hearing that although that's the goal, it probably is not something that CCC and the CDC can, I guess, provide. So the question is always, how do we, I guess, and I know that we should leverage resources and try to partner as much as possible. But the bottom line is that by the time I've convinced my patient that they have to get that colonoscopy, or not to be afraid to get that mammogram because it won't hurt as much as they think it will, if they don't have the resources and the funding to get it done, there's very little opportunity sometimes that I can say, like, okay, you can get your mammograms in October because I know there's a bunch of screening programs that we can get you a free mammogram, right? But there isn't a lot of free colonoscopies going around out there. So I just am always challenged with trying to understand how do we achieve equity in areas like cancer when there really is not a funding source for everyone. So that is something that I just would like to, I'm always thinking about, like, how do we get around, especially when the truth is that we just can't get some of the procedures done for patients who cannot otherwise afford it. And the answer, the people are always shunting us to, like, go to the Department of Health. What can the Department of Health do? And then they come to us, and I don't know if there is an answer that we can provide or give to them. So it's more just like a topic for thought and discussion, because unless anyone can help me about different resources that I'm not aware of. But equity is always a challenge that we're trying to achieve, but it's just not a reality to me that that I sometimes am struggling with, not as the medical director for the Department of Health, but just as the doctor when patients come to me and I'm like trying to get them the care that they need. So I don't know if anybody else has any thoughts or comments on it.
And I would like to say, and I absolutely appreciate that. I do think that if I could share a story, one of the things that happens, and I think this is what the coalitions can really do well, is to make sure that people understand, what these issues are, so that decision makers understand what these issues are. When we started the breast and cervical program, we didn't have the Treatment Act to make sure that women who were diagnosed with cancer actually had access to treatment. But because of I can't say it, but it's the A word that starts with an A and it ends in a Y, if you want to look at it like that, and the D is right behind the A. And my ACS colleague can say the word. But because of that, the info sharing and because of the fact that we made people aware of what the issues were, then we were able to really push to get the Treatment Act so that we can get screening behind it as well. And I think it's the same thing with everything that we look at. Make sure that people understand, so as coalition leaders and coalition members, we each have a role. And there are things that you can do that I may not be able to do that I think are absolutely important. If you're recommending fit testing for someone, make sure that they understand that if it's positive, you got to have a colonoscopy. And then make sure that there's somebody who can give them the colonoscopy, and that there's somebody who can follow that up if there are issues. So I agree. There are still issues. It's not all, yes, come, and we can do this, that, and the other. But I think one of the things that the coalitions can do and have done well is make sure that people understand the issues, and that's how we bring about policy changes that will help to address those issues.
Yeah, I'm Dr. Lillian Santos from the American Cancer Society. Just following up on her question, we'll be in these 2 days, sharing some of the things that we have done at the beginning of the coalition and the new coalition. But I think that one of the big wins, and I want to kudos to Cancer VI and American Cancer Society, you have at your table, it says a patient resource guide. I think this was one of the best wins and big wins of the beginning, and I think it's just something that you should learn about, because we have identified as a group all the needs that you have and the resources that right now are available on the island. And one of the things that I'm proud to share, that the American Cancer Society does have a mammography, free mammography program, and we're granting here in St. Croix and St. Thomas to provide to underserved and uninsured women. And also, we are also including a grant for colonoscopies. However, it's true that access to some of there's no fit test here available. If they don't have the labs to do it, they don't have the access. So if you don't have a specialist, and I hear that some of the challenges is the time that you have to wait for an appointment for a colonoscopy, that's following up on, we could do the plan, she's right. But access to care with the resources they have on the island, we have to be very realistic and not dream about a plan, but make it an action plan that is feasible here on the island. So definitely, yes, there are more resources that maybe as an education to the community of what is available. This is available, maybe a lot of people don't know it, and maybe working with the physicians, primary care, and specialists that the coalition has worked on these resources locally, and there's more than what you maybe imagine available right now. That we need more, definitely we need more, but we have to try to make it work. So I just wanted to share that, and you have it at your tables, the brochure.
Thank you all.
Thank you, Nikki, for such a comprehensive presentation. So I want to share a little bit about the structure of the Department of Health. Nikki mentioned 3 programs under that one CDC funding source. The National Breast and Cervical Cancer Early Detection Program, which the Department of Health had that funding source years ago, and then we no longer had it, and we were just able to get it back under this 5-year funding cycle. So that's an accomplishment. Thank you to the family planning team and Dr. Valmont for helping to write that. Then we have the National Comprehensive Cancer Control Program, which brought us here today, and then we have the Cancer Registry Program. So collaboration is key, as she says. The good thing with the structure of the Department of Health is that those 3 programs fall under me. So collaboration is easy. So sometimes I look at it and, oh, it's a lot of work, but I could just pull on, hey, I need you to do this, hey. So it's awesome. So that's a good segue into our next presentation. We know data is important, and the community is always asking for data. So we're using this summit as an opportunity to share the data that we have. And with that being said, I would like to welcome Sandra Singh Charles up to do a presentation on she's going to provide updates on the cancer registry. Sandra is a native of St. Croix, U.S. Virgin Islands. She's a territorial cancer registrar at the Department of Health with over 23 years of experience in public health. She holds an Associate of Nursing degree from the University of the Virgin Islands and a Bachelor of Science degree from Nova Southeastern University. And she has held numerous roles at the Department of Health as a diabetes project manager and the public health preparedness deputy director. She is also involved in multiple community organizations. Let's welcome Sandra Charles. Yes.
Good morning, everyone. Thank you, Dr. Fredericks, for that introduction. Today I will be presenting on the Virgin Islands Central Cancer Registry updates. Next slide, please. Okay, so the VICCR is housed under the Department of Health Chronic Disease Prevention Program. We are under the leadership of the Commission of Health, Justa Encarnacion, and Dr. Linnea Fredericks, who is the Chronic Disease Director. We currently have 3 staff on board. Veronica Rivera Lopez, who is a certified tumor registrar, and John Orr, who's a data analyst, and myself, who's a cancer registrar. Next slide, please. Funding. So the VI Central Cancer Registry is funded by the Centers for Disease Control and Prevention under the National Program of Cancer Registries. Our funding cannot be used to collect historical data prior to 2016, collect data from healthcare providers. However, we were granted a special exception to proceed with data collection. Our funding cannot also be used to provide cancer care, example, screenings, diagnosis, or treatment plans. Next slide, please. Collaborations and partnerships. So we have partnered with the American Cancer Society in a collaborative effort to reconvene the USVI Cancer Coalition. The Cancer Registry staff is also a part of the USVI Cancer Coalition and have been engaging in meetings that have allowed growth and partnerships. Next slide, please. What is the VI Central Cancer Registry? The VICCR is an epidemiological surveillance system designed to collect information regarding incidence, distribution, risk factors, and mortality of the disease. Why is this important? This information is essential to public health professionals researchers, and the medical community and policy makers to understand and address the cancer burden. How is this data collected? This information is acquired through active reporting of data for cancer cases in places where patients are diagnosed or treated. Data sources. So we have remote access to patient data from the hospitals, Wang F. Louis Hospital and Snyder Regional Medical Center, including federally qualified health centers, the Frederiksted Health Center on St. Croix. Pathology labs on island and off island. The VI Vital Statistics Office provides death certificates with cancer as the cause of death. Also, mainland cancer registries, for example, the Cleveland Clinic in Florida. The VICCR has agreements with states, other states' central registries to obtain information on USVI residents who are diagnosed or receive treatment off-island. Cancer data collection standards. So cancer data is collected from healthcare providers only. The VICCR does not have any direct contact with patients. So the data is collected based on the list of required items from NPCR and NACER, and includes diagnosis, information, date and primary site, demographics, staging at diagnosis, and first course of treatment. So what we have, next slide please. So what we have here is a 2016 cancer incidence report for the U.S. Virgin Islands. In 2016, there were 525 newly diagnosed cancer cases. There were 237 on St. Thomas, 25 on St. John, and 257 on St. Croix. The top 3 primary sites, newly diagnosed primary sites for males were prostate, hematopoietic, and colorectal. The top 3 primary sites for females were breast, uterus, and colorectal. So as you can see, in 2016, cancer was the second leading cause of death in the U.S. Virgin Islands. Next slide, please. I just wanted to state, too, that the incidence can change as more data and tumors are recorded. Here you can see the 2016 cancer incidence with the number of new cancer cases broken down by sex and race. So the data has been broken down by females and males, and the races were specified as white, black, other races, race unknown, black female, white female, black male, white male, Hispanic female, Hispanic male, other races female, other races male, including unknown race female and unknown race male. In this table, the 2016 incidence was broken down by the number of new cancer cases by sex and age group, with the age groups ranging from 0 to 4 being the lowest to 85 plus being the highest between males and females. We are not showing the statistics for cells with fewer than 10 cases. Next slide. Okay, this table displays the top 3 primary sites in 2016 by age groups for females and males. So, as you can see, the age groups range from 25 to 34, being the lowest, and 85 plus being the highest. The top 3 primary sites for males were breast, uterine, and colorectal. And for males, the top 3 sites were prostate, hematopoietic, and colorectal. So I just wanted to share with you all that this report also, it has not been published as yet. Here, the data is broken down by the top 3 primary sites in 2016 by race for females and for males. The races reported were black, white, other races, and unknown. Next slide, please. Okay, so here we have the 2017 cancer incidence in the U.S. Virgin Islands. There were a total of 356 newly diagnosed cancer cases in 2017. In St. Thomas, there were 168, St. John, 14, and St. Croix, 172. The top 3 primary sites for male in 2017 were prostate, colorectal, and hematopoietic. The top 3 primary sites for females were breast, colorectal, and corpus uterus. The 2017 cancer incidence decreased in comparison to the 2016 cancer incidence, where more statistical information, whereas more statistical analysis is needed, a decrease in the numbers was expected due to the impacts of Hurricane Irma and Maria on the healthcare system in the Virgin Islands. Next slide. Here you can see the 2017 cancer incidence with the number of new cancer cases broken down by sex and race. So the data has been broken down by females and males, and the races specified are Black, white, other races, race unknown, Black female, white female, Black male, white male, Hispanic, female, Hispanic male, other races female, other races male, including unknown race female and unknown race male. In this table, the 2016 incidence was broken down by the number of new cancer cases by sex and age, with the age groups ranging from 0 to 4 being the lowest to 85 plus being the highest between males and females. Next slide. This table displays the top 3 primary sites in 2017 by age groups for females and males. So as you can see, the age groups range from 25 to 34, being the lowest and 85 plus being the highest. The top 3 primary sites for females in 2017 were breast, colorectal, and uterine, and for males, the top 3 primary sites were prostate, colorectal, and hematopoietic. Here, the data is broken down by the top 3 primary sites in 2017 by race for females and males. The races reported were Black, white, other races, and unknown. So 2016 and 2017 incidence reports, the information contained in the incidence reports and tables have been created using the data available in the VI CCR database as of June 5th, 2023. The data numbers can change as more data or tumors are reported and is included in the database. We are currently working on identifying the location of the estates, and this information is forthcoming. The demographic breakdown is preliminary data and will not be shared with stakeholders or available for publication until finalized. The 2016 and 2017 cancer incidence reports can be found on the DOH Facebook page or the DOH web page at the link below. Current issues identified while collecting cancer data. Diagnosis. Some primary sites, for example, the lung, are referred out of the territory for diagnosis. Staging. St. Croix participants that needs a staging bone scan has to travel to St. Thomas or out of the territory to get one done. And this is most common in patients with prostate cancer. There are currently no PET scan machines in the territory. So if patients need a staging PET scan, the patient has to go off island. Treatment. There's currently no radiation treatment facility in the territory. Moving forward, electronic reporting of cancer pathology labs. We are currently in conversations with a contractor assessing the possibility of receiving electronic pathology reports for patients whose specimens have been reviewed in off-island pathology labs. 2018 to 2010 incidence data will be completed by November 2023 in time for the 24-month NPCR call for data. 2021 to 2022 incidence data will be completed by January 2024 for the 12-month NPCR call for data. This is a list of the cancer registry staff contact information. Dr. Linnea Fredericks, Veronica Rivera Lopez, myself, and John Orr. Thank you all. Now I'll take any questions that you all may have, and if I cannot answer it, I will defer it to Dr. Fredericks.
Good morning, and thank you for your presentation, Sandra. Two quick questions. Does your registry look at prevalence data, or is it just strictly incidence in the territory?
It's strictly incidence. We do not look at prevalence data.
Okay. Okay. And then second question is, I can't remember from your first slide which showed your sources of data. Is the GVI large group employee Cigna plan one of your sources of data? And if not, do you have any thoughts on maybe partnering with them? Because they're a great source of prevalence data in the territory. They're looking at all of the claims. And I think for their 2021 to 2022 claims, it's about 526 persons who are living with cancer in the territory, and as evidenced by the claims data. And their top three, the breast, the male reproductive, and I think neoplastic are their top three. So it would be good to partner in the future and make that connection.
Thank you for that recommendation again. And this is not the first time Tasha has recommended that to me. I actually got the data from Cigna, and I was told I can't share it. But thank you for sharing it. We'll work on it. Okay. But I do have the data, so I do intend to use it however I can, but it wasn't included in any of our presentations today.
Hi, good morning. My name is Marta Sanchez. I have a question and a comment. I saw an incidence and mortality for male, like lymphomas, leukemias, and myeloma. Do you have any idea of risk factors related to that? That's my first question. And my comment is that I work for the Comprehensive Cancer Control in Puerto Rico that also has the cancer registry in the bundle of funding that CDC provides. And we have a law that encourages and orders to report. So I feel free to share with you the law so you can probably implement some kind of policies in the island to make the reporting, compulsory. So this is my comment and my question.
Okay, I can respond to the law. We do have a law in place, a legislative law mandating that healthcare providers report to the Central Cancer Registry. We have tried, and we have also met with them individually at their healthcare or physicians' offices, and we've prepared packages explaining, what the Central Cancer Registry, how they can report. We've shared the website that they can download the form. We've shared copies of the forms. A letter has been sent to them from the Commissioner of Health. So they know that they are required to report. However, we do try to assist them because some of them do not have staff in place to fill out the form and send it to us. So we do go to their offices and try to help them.
And the question about the risk factors for
So we did recognize that there's a spike in myeloma cases. Actually, Dr. Del Jaco had reached out to Veronica, our certified tumor registrar, and that is something we do plan to investigate. So at this time, we do not have any further information on it, but we did recognize that something is going on, that we have such high myeloma cases in comparison to other territories and states. Okay. Any other questions?
And to your point, Dr. Fredericks, I'm not sure if you're the one who can answer this, and I don't know if this will be covered during the two-day period. I'm sorry, good morning, everyone. Daveline Trusty, Program Manager for Health Disparities Program here in the Virgin Islands. Have we explored or are we collaborating with any agencies that help us understand environmental risks to the cancers that we are collecting in our data?
Yes, we have been working closely with the EPA. We have been attending meetings and working with them. No more questions?
So I just wanted to follow up with the previous comments about multiple myeloma. So I actually have already reached out to the HEMONC doctors in the territory, asking them to actually submit the information, their case reporting for multiple myeloma, because of that recent sort of spike in cases that we've been, that we sort of just sense that there is like a higher number. So they're already working on their cases within their practices to submit so that we can do some further investigation, research opportunities even, to further look into it. So we'll be working together with the providers and chronic diseases cancer registry to look more into that. So that's something that's in my pocket that I'm working on. And additionally, just sitting here thinking, we are always looking for partnerships, but we will partner within the divisions within the Department of Health, as we have Daveline Trustee here, who actually has a pockets of community healthcare workers who need to actually look into the different needs. So I'm sitting here thinking that would be a wonderful opportunity for the community health care workers to actually go into the hematology and oncology offices to look at the reporting challenges, to work with the offices to kind of share the information a little bit better, and then also to reach out to see if there are patients that they can actually help navigate their situations. So that's something that we can start to work within the Department of Health to start to use our resources a little bit better. So that's just what I wanted to just mention, that we have resources that internally that we can leverage.
Thank you.
Just one last tidbit. So as an 11-year survivor of living with multiple myeloma, when I was diagnosed here in the territory, I was told it's not just that our incidence of multiple myeloma is higher in our jurisdiction, but it's the onset and early age. So I was diagnosed in my mid-30s, and what my oncologist here told me is that she was noticing a trend earlier and earlier. There are people in their 20s, like mid-20s, who have been diagnosed here. And normally for that particular type of cancer, it's not until you're like in your 60s that you really see persons being diagnosed. So definitely something is happening in the territory, and we need to kind of drill down a little bit more into that. I mean, it could simply be genetics based on, makeup of our ancestors that were placed here, but we won't know if we don't look.
Thank you for sharing that. So we'll take one more question.
Well, some.
Good morning, and thank you for that presentation. I just wanted to comment that as a provider, I love the easy button, and I think these little scan codes, that if they could be put on cards that all of us could put somewhere on a wall in our office with a fillable form, that'll make it very easy for us to type in and submit cases if there are some. So the easier you can make it for us, the better. Amen.
Thank you, everyone. I'm sorry, Ms. Hunt has a question.
I just have a question about the data. Are client identifiers removed by the time this data is all aggregated, or no? No client identifiers? Okay, and my other question, I know you said that you haven't had the opportunity yet to do a deeper analysis, but just having looked at the data, to what do you attribute the very small number of the cancer prevalence among Hispanics?
So, I mean, for this reason, we only take what we get, and we've been investigating. Mm-hmm. So it would have to probably go back to access to care, people going in and getting screened. So that's a deeper problem outside of the cancer registry. So they're just providing us with the data, but this group of people here, that's what we'll be looking at. Why are Hispanics not going in to get screened? And we're about to share some breakfast data in one of the presentations that will give you a better understanding of that breakdown by race and ethnicity for colon cancer, breast, cervical, and I think that's it, colorectal, breast, and cervical cancer.
Okay, great. Thank you.
You're welcome. Okay. Okay, so now we're going to take a 2-minute break so you guys can stand up and stretch if you need to. 2 minutes before we move into our next presentation. Stretch your legs. Presenter is Miss Michelle Francis. Michelle Francis is the Executive Director of the Office of Health Information Technology. In this role, Michelle leads the development of USVI Health IT strategy and implementation. She advises on federal health IT standards, policies, and investments. I'm hearing a lot of talking in the room. Great networking. So Ms. Michelle Francis, as I was saying, she creates spaces for collaboration on transformative health IT initiatives that include the implementation of a territory-wide health data utility, telehealth, data interoperability, privacy, and security. Michelle, a native of St. Croix, returned to the USVI from Chicago, bringing over 20 years of leadership, business acumen, and vast consulting experience. First, to the Department of Human Services as the Director of Strategic Operations and Planning, and now in her current role. Let's welcome Michelle Francis.
Good morning. Let me try that again. Good morning, because I know everybody their break was interrupted. I'm sorry. I do want to jump in and say thank you to Commissioner Justa Encarnacion, Dr. Fredericks, also Program Manager Ms. Henry. Thank you for all of you who have made today possible and for your commitment to the health and wellness of the territory, demonstrated through your collective leadership and commitment to advance care through events like this. These events open the door for new information, new conversations, resources, and partnerships that enable true change. Next slide. So today we're going to talk very quickly about the impact of health information technology on cancer prevention and control. I held my question on the last session because I wanted to ask, last year when I met with Kevin Hodge and we kind of spoke through email, the cancer registry was partially digital. So one of my questions would be, where are you on your digital journey? And we can talk about that later. Next slide, please. The Office of Health Information Technology exists to provide leadership in policy guidance, expert resources and services to enable innovative and transformative health IT solutions across the USVI in order to improve health and wellness of Virgin Islanders. The office is grounded in the strategic plan that identified 3 focus areas. There's a few people in the room, including Commissioner Encarnacion, including Dr. Christensen, who participated in the strategic plan. It was a community-wide effort, also including Gary Smith, Director of Medicaid. The 3 focus areas were empowered patients and providers, health IT infrastructure, and a capable and resilient workforce. Next slide. So with a little understanding of what the Office of Health IT does and about 9 minutes to jump in, let me ask, how many of you have your cell phone with you today? I'm going to guess 99% of you. How many apps do you think you have on your phone? Just hazard a guess. Plenty apps. What are your favorites? Just throw something out. What's your favorite app on your phone? And what do you wish you could have on an app? Anybody have that at the top of? You just request money, right? That would be the easy button I want. While our responses are very varied, they all center around a few things: convenience, time savings, cost savings, or just getting money, and access, easy access to some sort of information, whether that's music, your banking, whether it's what other people are doing on Facebook and Instagram, or being able to communicate through WhatsApp. So I think we can agree that technology has radically transformed not only society, not only things like the music industry, but our personal lives. Today we're going to focus in this time together on the importance of digital tools and health IT systems and how they can impact improvements in cancer care, prevention, and control. Next slide. Much in the same way that digitization has impacted what we listen to, how we listen to, consume, produce, and distribute things like music. We went from records to tapes, and someone can, I'm sure in the room, tell me what came before records. Records, tapes, CDs, to iTunes, SoundCloud, YouTube, and Spotify. Digitization has vastly improved the way the patient has become the center of their care. Digital health has become particularly important for resource-constrained areas like our own. Some of the resource limitations were just mentioned as questions came up about how we're accessing information for the registry. Digital health options can fill the gaps in traditional healthcare delivery because, as many of you mentioned, with the apps on your phone, digital technologies are the most efficient and often accurate way to collect, compare, analyze, and share patient-generated health data. For context, so that we're all singing from the same songbook, when we refer to digital healthcare, next slide, we are referring to the ability for clinicians, patients, caretakers to make use of digital technologies. There's a variety: cell phones, apps, tablets, laptop computers, video conferencing, telehealth monitoring devices for remote patient monitoring and interaction. And we use all of these in order to more efficiently, effectively, and safely provide patient care so that we can more effectively monitor progress and outcomes, so that we can more effectively and efficiently conduct research, as we were talking about, and enable things like predictive modeling and data-driven decision-making. Up here, we've got the National Institute of Health definition of digital health. I won't read it out. As those of you who are working in the field are aware, cancer care, particularly, is a complex web of care consisting of multiple providers and multiple handoffs. It's not just one oncologist. You're dealing with a very diverse web of care. In the territory, it's even more complex because, as you heard, a good majority of our patients have to travel off-island at some point during their care. Especially for specialty care like cancer. Again, Director Smith can attest to this in the spend that Medicaid alone puts out for sending care off-island. So with that in mind, clear and consistent communication between providers is difficult, sometimes impossible. Cancer care data from 2020 indicates that in 2020 alone, 19 million new cancer cases were diagnosed. So hold on to that number. In addition to that, with the advances in cancer care and treatment, patients are living longer, which is what we want. But this means for providers that they've got an increased workload. They're navigating not only their patients and caring for their patients, but the new cutting-edge ways to communicate, to diagnose, to support, and to intervene. The reality of multiple transitions, the increased patient workload, and the high cost, as we were mentioning, of cancer care, we can underscore and understand the critical need to harness innovative digital tools. This is a passion area of mine. I've worked in healthcare for 20 odd years. I worked in hospitals, healthcare systems, implementing EHR systems, helping to build HIE systems, building accountable care entities. So it's nice to talk about all of this, but it comes down to the brass tacks. How can we do this? How can we give providers and patients a more clear path to Dr. Hunt's question, to affordable care that includes easy views of options, the costs? How can we help patients compare and contrast? Modalities in treatment. How can we ensure that there's one comprehensive patient record and the ability to communicate across providers, across entities? Where do we start? Next slide. As a small territory, it's important, someone mentioned it, I think we mentioned it at the top of the hour, to collaborate in forums like these and across the territory, as well as in our day-to-day planning, internally to DOH and across agencies and organizations in order to chart a holistic and integrated path to identify and implement the appropriate digital tools that address our realities. Again, our realities being power outages, the need to travel for care, and the reality that we have a lot of outdated systems, and in a lot of cases, we are still very much on paper. So next slide. In order to achieve the transformational changes that we're going to talk about, that we've been talking about, that we want and need, I would advocate that we have to work transparently, harmoniously, and in a more cohesive way to ensure that we can envision, plan for, and harness affordable, sustainable health information technology solutions. So what would those be? I'm going to highlight 3. One being a fully integrated health record system by institution. The 2 hospitals are working to upgrade their EHR, electronic health record system, Meditech, to the latest, which is Expanse. Why is it important to mention this? Because again, creating one patient record so that any provider along the continuum of care is able to go into the record, see notes, see medications, so that the burden is not on the patient to remember what did my doctor say, what did they ask me to do, what medications have I been on for 10 years, who can remember that? So that people are not dragging a suitcase up to the States when they go full of paper and old medicine bottles, like my mom has done many times. It is important for us to support and advocate for, and policy advisor Tasha Phillips-Dorsett and I are vigorously advocating for continued financing to support the EHR upgrade for the hospitals. A core challenge that all providers face is getting access to all the data so that they can provide the best treatment. So while the Department of Health is utilizing Greenway and Energy to secure, in order to secure all the modules, we talk about things like, oh, well, then get an EHR. But each module costs something. So again, it's important to talk about this so we're all aware, so that we're advocating not only for concepts, but we're understanding the reality and advocating together. Number 2, a digital public health registry. So we talked about the registry. I will push for, of course, digitizing what we can. And I'm going to mention here very briefly that inherent to these conversations for me is security, because that comes up right away as a concern. But if they're sharing my data, have they removed patient identifiers? Is it secure? Can a system be hacked? And what I say as well, while no system is perfect, but in an electronic health record, in a registry, there's a digital trail. Right now, someone can pull open a file drawer, go through, see what they want. So remaining in the past is not our security. And we do have federal guidelines. Someone brought it up. We're not alone. We don't have to chart this in the territory on our own. We're not coming up with policies on our own. There are federal standards and guidelines, including what kind of EHRs are certified, what are best practices. We have partners in the CDC, and Office of the National Coordinator, at Centers for Medicaid and Medicare that draft federal policies that guide us. Over the last 10 years, the work I've done in EHRs and working with HIEs has seen exponential change and positive advances in low-cost, real-time technologies to view images, assess disease, track movement, assess behavior and social interactions, environmental toxins like we were talking about, so we're not guessing about why we're seeing spikes in incidences, and other important health factors. These exponential advances have been made possible due to the inclusion of things like artificial intelligence, machine learning capabilities, and other sophisticated technology. Cloud computing has made it possible to reduce the requirements of an organization to have their own mini data center. Huge. There used to be the days where it was like, okay, if we're going to have this technology, we also basically need to build our own data center, which was a ton more money. As discussed, the need for information and the volume and complexity of cancer data alone, it continues to increase. In light of this reality, the urgent need to capture and share data in a unified, secure, and accurate manner becomes more critical. As you are well aware, cancer surveillance data is used to monitor cancer trends over time. It guides planning, it guides the evaluations of cancer control programs, helps set priorities for health resources and research services. Therefore, adopting digital tools and services to ensure consistent, quality cancer data collection at all points of care into one system is of utmost importance. It provides a more complete picture for public health reporting and enables the clinician to more accurately create treatment plans, care plans, and even communication plans. These tools also allow the patient to remain engaged, informed, and to have easy access to their care team in a consistent way. So it goes back to asking all of you, how many apps do you have on your phone? No one said one. I have one app. It's like, no, more apps for more things. Because it makes life easier, it helps us to engage in our lives, so we want to do that for patients as well. That's already come up. So one of our providers mentioned it. You make my life easier if I can just scan this QR code. So as we talk about collecting data, we talk about making it easier. Of course, I advocate for utilizing the tools that are already out there, the technology that's out there to do that. Digital tools have enabled a powerful national registry through the CDC's National Program of Cancer Registries. And as mentioned, it includes data from the USVI. Our ability to share data nationally enhances our ability to create a trustworthy and comprehensive cancer plan that can more accurately identify the gaps in service and the barriers to information and services. The third that I'm advocating is a core component for transformational change is interoperable systems. So it's one thing to have everybody has the latest and greatest electronic health record in their institution. We get a digital cancer registry and all the other registries are digitized. But then how do we get all these systems to talk to each other? That's called interoperability. Interoperable systems are important so that everyone can speak in the same language. All the data and information, again, is able to be shared even outside of the territory without placing that burden on the patient or on their primary care provider. Interoperable systems and the territory's need for a health information exchange and health data utility that enable these varied systems to communicate is super critical as patient care is dependent on access to data, comprehensive data. Our ability in the territory to conduct appropriate clinical research that's specific to our people and what we're seeing leads to life-saving treatments and breakthroughs. Without the ability to modernize and appropriately digitize our systems to securely share information across the various channels and points of care, and our ability to continually innovate, little progress will be made in our approach to cancer. At the Digital Health Summit this June, the governor and I were able to announce a major leap in our journey towards the territorial HIE as we announced the launch of a pilot through funding from the Office of the National Coordinator with CRISP Shared Services. And you'll be hearing more about that, including all of our key stakeholders, the hospitals, Department of Health, the FQHCs, Department of Human Services, and Medicaid. This Cancer Summit and the open conversations that are about to take place are critical today. Collaboration, as you've heard, is critical. Funding the important work and advances that we all seek is critical, and that will also make a significant and life-changing impact on cancer care in the USVI. Final slide. The Office of Health Information Technology looks forward to continued opportunities to partner and to work on developing this cancer plan. Thank you for the chance to participate and to share insights from the digital lens.
Okay, we have time for one question. We're a little behind. Okay, I don't see anyone with their hands raised. So we'll move along to our final, Barb, I'm sorry.
I don't know if it's a relevant question, but Michelle, in speaking to the digital age, so many of our cancer patients in the community don't have access to digital information. So I'm just wondering if there is an opportunity for information to be streamlined that isn't digital, or ways to get it within the communities of people that don't have access to. I understand the whole concept of systems being put in place for healthcare providers, that kind of thing. It's just a lot of our patients and warriors don't have access to that information, so.
Yes. Specifically to answer that question, a lot of I don't want to misquote this, but the territories in receipt of over $80 million in broadband grants to address that in a variety of ways. One, even in making sure that there's high-speed internet access in all communities. So VINGN is working on that. That's our middle mile provider, the Bureau of Information Technology. And I was able to work on a plan for a grant for $14.5 million that puts community hubs with digital centers so that you don't have to have your own phone, you don't have to have your own tablet. These dollars will go so that people can go right in their community. So we mapped out the community where, we even identified a few churches, existing places that people are going to for care, where a mini electronic hub would be placed so that telehealth visits can be conducted. People could do even learning, remote learning. They can establish accounts. They could log on to patient portals, because we've, especially in the territory, the point you just raised is very pertinent. So not only addressing that some communities don't have high-speed internet, that's being addressed, but also getting nodes into the communities that provide everything from the iPad or the laptop, the tools for patients to be able to communicate securely with providers.
Hi, quick question, piggybacking on what you just said. Will the patients have access to the same information the doctors have with respect to their records?
That would depend on each electronic health record and the patient portal they provide. So, yeah.
Hi, I'm so sorry. Just to answer that, as a provider, I think that, so patient portals are going to be different to the electronic health record system. So the patients will have access to their records, meaning like their lab results and things like that, but not necessarily like patient notes and documentation that would happen, like, as it relates to a medical record. It's different what patients can view, but they always have access if they would like to go to the hospitals and request for things like that. Of course, it's their right, but it's also very important to understand that patients, even when they get their information, it's still very, very important for the interaction to happen with the provider so that they can explain and understand what those things like mean. Okay, so as I am all about access and the digitization so that we can have, but as a provider, it scares me sometimes when my patients come in and they're telling me what they interpret with the information that they have already received. So it will not be exactly what the providers have access to and what it is, but it's very important that once we have access to patient portals and records, that the interaction within the patient and the physician still happens so that there is proper counseling and proper patient planning and coordination, that the patients are included, but they also still see the value of what the providers have to play for their plans.
That's also a legal question, and an attorney, a medical attorney could also answer that question, because as each patient has full authority when sitting down with their physician to actually have access to the entire chart with someone that can actually explain what's in that chart. So that's legal. That's something that's legal. But I appreciate everything that has been said in reference to that. Where's Michelle? One of the things that we've spoken about time and time again, and this has to do with a little bit of what was just speaking about in terms of patient records, right, is HIPAA and the full understanding of what HIPAA is and the fear of having your information where you may not want the information from your interpretation. So as we plan for improving digital health IT within a territory, how, in terms of training or explanation, so what's the link, what are we doing right now so that we can have a platform, a basis of full understanding of one, what HIPAA really is, really and truly, which gives you so much rights as a provider. But what are we doing from a government standpoint to assist the community in being more comfortable with digital IT, health IT?
So I'll give the most brief answer that I can to that. One, for my office, the focus is going to be on, we've been really focusing on providers so that we can figure out how to build a system. But there's not only patient education needed on HIPAA, there's provider education, because we kind of abuse it. We use HIPAA as a way to say, no, we cannot share information. But there's the patient access rule. I would challenge anyone to define for me in this room the patient access rule. And how do we balance what the Health Information Portability Act put in place to summarize, and have created a document to summarize HIPAA and the appropriate uses, because that's thrown up as a way of just saying, no, I don't want to participate, I don't want to share information. So there's provider education needed and patient education needed, both on the new rules that, again, Director Smith can tell you, the patient access rule dings Medicaid from receiving what is it, like 2%, and the hospitals know this, if you don't provide access, and there's rules about what minimal access is to your patient information, you get dinged from your reimbursements. So understanding what is required and minimal, and then building systems. HIPAA is now built into a lot of the HIPAA requirements into the majority of electronic exchange information. So that's why it's important to know when you're looking at vendors, are they pre-certified, have they been certified? Because certification says you've met the federal requirements for sharing appropriately, for meeting. Even there's also, aside from HIPAA, there's FHIR standards, which is Fast Healthcare Interoperability Standards. There's HL7 standards. So educating our providers on, in addition to HIPAA, there's all these other standards. Healthcare is the second most regulated industry behind banking.
We know that.
Yeah. Yeah,
right?
well, but patients, I think, need to know that for some of that security, that there's 10,000 layers of eyes. Can you get around them? Yes.
Well, if I may, one of the things too, and this is as we go ahead with the digital health IT, is really and truly showing the public what data can actually do. And that's why this planning meeting is so critical. If we could show, we've been getting a lot of questions about cancer these days, and where, in terms of demographics, that we do not have the capability of answering because we haven't pulled the data in that respect years in the historically. But these are things that we can change today. And if we could share that information with the public so that they can see the impact of the data gathering, it'll be easier for them to see how they can help us grow within our healthcare.
I just, can I go? Just very briefly, does everyone know about the Affordable Connectivity Program, ACP? Because individuals who have SNAP, WIC, Medicaid can get a device to provide that connectivity almost free of charge. All of our carriers should have it. I know VIA has it, and they're willing to go out and explain it to different groups so that people can be sure to be able to access it. That's all I wanted to say.
Good morning, everyone. If I may, as far as the HIPAA conversation is concerned, there are 3 exceptions to HIPAA: treatment, payment, and operations. Every time you go to the doctor, you're required to sign a document that gives the provider permission to share your information for billing purposes, number one. So once you understand that, that could help. You're educated. Every time you sign that and you read that, that's education. So you're being exposed to understand that there are reasons for sharing data, number one. Number 2, sorry? Oh, I am Ruben Malloy, Assistant Commissioner at the Virgin Islands Department of Health, and this is my beautiful team led by Commissioner Encarnacion. Secondly, from a public health perspective, we approach data from a population management perspective. So as you saw with the presentation earlier, the information is aggregated and de-identified. So there's no concern about being identified individually in those presentations. You're well aware of it from the COVID-19 perspective when the daily epidemiology report came out and we reported that information. Everyone clamored for that information. It is powerful information. It is soothing information. It goes a long way in making you feel a lot safer. It went a long way in making you feel safer. So, third, there are systems that are already established that even though the source may not be automated, as a part of doing business, you have to submit your claims. So when you submit your claims to providers, they cannot. They have to have an automated system. So that is a way of automating every provider's information if you're billing for your services. Even no pay, non-pay, when the hospitals treat you, your information is collected. That information is available from those services, so from those sources. So we have available information from a Department of Health, public health perspective that comprehensively for the entire territory, for the entire population, could provide valuable information and decision support.
So we will allow one more comment, and then I want to be respectful of everyone's time so we can try to get back on schedule, but I can't deny Mr. Smith.
Good morning, Gary Smith, Medicaid Director. And Barb, it's finally nice to meet you in person, even though we haven't officially met. We've spoken on the phone a lot, but wanted to address your question. So, and Michelle, mentioned it. CMS mandated that all health plans make patients' information, i.e. claims, medications, labs, patient access interoperability is what it's called. That was mandated in 2020. And the Medicaid program is mandated to make that available for their patients as well. So that is coming. And she is correct, we get dinged 0.25% on our FMAP, Federal Medical Assistance Percentage, which we receive federal dollars from in paying claims. However, we've been waived of that, so we're not getting dinged. But that information is accessible right now. And I had a visit with VIGI the other day, and after the visit, I got a text immediately stating if you want to access your information and see about your visit, click the link. And there are several physicians in the territory that have that portal available, in their programs.
Okay, thank you all for your rich conversation. And we will move along with our agenda. Next, we have a presentation by myself and Miss Letitia Henry. You guys already know me, so I will introduce Miss Henry. So Miss Henry only been on the job about 3 months, but she had a really warm welcome. As you can see, she had 3 months to help me organize this. So meet Ms. Letitia Henry, the accomplished National Comprehensive Cancer Control Program Manager with a bachelor's and master's degree in public health and an associate degree in culinary arts. Letitia brings a wealth of knowledge to the team at the VI Department of Health. She is excited to hit the ground running and assist with the development and execution of the Comprehensive Cancer Control Plan with confidence and enthusiasm. Just waiting for the slides to pull up on the screen. Okay, so we will be sharing more data. So for those of you who love data, yay. This data that I'll be sharing right now is data from our 2022 BREFS survey. So what is BREFS? BRFSS, it stands for the Behavioral Risk Factor Surveillance System. It's a telephone-based population survey where we randomly select persons from the population and we call you to ask you questions about your health behaviors, whether you access screenings and so forth. Do you use tobacco? Do you have this chronic disease, that chronic disease, and so forth? And this is always my shameless plug. The survey is ongoing. If you receive a call, please participate. Help us gather this data. This survey is sponsored by various CDC divisions, and it sits within chronic disease as well. I'm going to be sharing data on breast cancer, cervical cancer, and then colon cancer. So it's a lot of numbers, so bear with me. The first question that we ask, so I have a whole lot of data. If you see something that's not here, my contact information will be on the screen at the end, so you can just send me an email and we can provide you with additional data. I'm supposed to say next slide, sorry. Okay, so the first graph that you're looking at asks about persons who have had a mammogram within the past 2 years. So this graph to the left was the entire sample, 1,500 people. That included males and so forth. So we're going to look at the graph on the right. This included respondents who either said yes or no, the female respondents. So women respondents age 40 plus who have had a mammogram in the past 2 years, 62.3% said yes, and 37.7% said no. We drilled down on that data to separate it by island, by age, and then by race and ethnicity. So women respondents age 40 plus who have had a mammogram in the past 2 years, those living on St. Croix, so the prevalence of the population on St. Croix who have had this mammogram in the past 2 years are 59.8%, on St. John, 75.4%, on St. Thomas, 64.7%. And this is self-reported data, just letting you guys know. When we looked at it by age group, persons aged 35 to 44, 59.3%, and it increased a little bit between ages 45 to 54 to 64.5%, and it continued to increase to 70.6%, and then it dropped off among women aged 65 and older. 57.4% of them stated that they had received a mammogram within the past 2 years. Now looking at race and ethnicity, women respondents age 40 plus who had a mammogram in the past 2 years. White women, the prevalence is 29.6%, black 66.4%, other races, we combine them, 58.25%, and then Hispanics, 79.9%. For cervical cancer, the question on the survey asks, have you ever had a cervical cancer screening test? So the graph on the left just shows the spread of data. We're going to focus on the graph on the right. So these are women who had a cervical cancer screening test. So the respondents that either said yes or no. 47.6% said yes, 52.4% said no. Again, broken down by island, women who had a cervical cancer screening test. On St. Croix, 49.5% of the women said they had a cervical cancer screening test. St. John, 82.7% said yes, and St. Thomas, 43.2%. By age, the numbers were pretty low in the younger population. Ages 18 to 24, 31.7%. Ages 25 to 34, 26%. We had an increase between ages 35 to 54. It went up to 60-something%, and then it dropped between ages 55 to 64, and then it increased again ages 65 and older. When looked at it by race and ethnicity, white women said 42%, 42.4% said they had a cervical cancer screening test. For blacks, 48.8%, other 58%, and Hispanics, 41.7%. So the next question I'm going to show is when last. So that's important. How long has it been since you had your cervical cancer screening test? And we combine the data for those women who have had cervical cancer screening tests within the last 3 years. And between ages 18, so most of the data, I'm not going to go over it piece by piece, but most of them range, next slide. So yes, so most of the data ranges between 80-something%, and then as women get older, they are less likely to do a cervical cancer screening test. By island, on St. Croix, 74.7% had had a cervical cancer screening test within the past 3 years. For St. John, 54.5%, and St. Thomas, 71.5%. And by race and ethnicity, white women had a lower prevalence of 52.3%, 77.9% for blacks. Hispanics had a prevalence of 78.2%, and then other 73.3%. Okay, so next slide, colorectal cancer data. The question that we highlighted, we decided to share from the breakfast survey is asking, have you ever had either a colonoscopy or a sigmoidoscopy? The graph on the left just shows the spread between all respondents, and then the graph on the right is what we look at. This is the prevalence for the respondents that either said yes or no. And 56.8% said they had received a colonoscopy or a sigmoidoscopy. And now looking at it by, next slide, now looking at it by island, St. Croix has a prevalence of 54%, St. John 62.4%, and St. Thomas 58.8%. By age, persons aged 45 to 54% had a prevalence of 45.2, 55 to 64 age, 56%, and persons 65 and older had a prevalence of 66%. And I think this is important to share. I'm taking my time because this is exactly the type of information we need when developing this cancer plan. When we look at it by race and ethnicity, 42.9% of whites said they had a colonoscopy. Among blacks, prevalence is 65.6%, other 34.6%, and Hispanic 29.6%. And then how long? Again, a very important question. And we'll show the data now for persons who had a colonoscopy within the past 5 years. The graph on the right, when we look at it by sex, 67.9% of males had a colonoscopy within the last 5 years, and 72.1% of females. By island, 73.7% on St. Croix, 60% on St. John, and 64.3% on St. Thomas. By age, persons aged 45 to 54 had a prevalence of 89.1%, and then it dropped off as people age. By ethnicity, whites had a prevalence of 57.7%, blacks 71.4%, and Hispanics 84.6%, other 68%. And then this is the last slide of data. So I just pulled off two questions that I wanted to share with you. We did ask about the at-home test to see what the prevalence is here in the territory. So the question on the survey asks, one stool test uses a special kit to obtain a small amount of stool at home and returns the kit to the doctor or lab. Have you ever had this test? And we can see only 9.9% of the population have had this test. I didn't even bother to drill down on the data because it was such little numbers. And then the other question asks, another stool test uses a special kit to obtain an entire bowel movement at home and returns the kit to a lab. Have you ever had this test? Only 2.24% of the population said yes. So that completes the data segment, and Letitia will now share some information she collected from some of you in this room regarding the cancer plan.
Okay, so the survey that I sent out to you guys prior to the summit, the purpose of it was to gather data to help us with constructing and implementing the cancer plan. It consisted of 14 questions, open-ended and multiple choice. An example question is, what cancer-related strengths does the USVI have that we should leverage in the USVI Cancer Plan? So now I'm going to discuss the questions that I thought related more to what we're going to be discussing over the next 2 days. The first one, so cancer-related strengths that the USVI has: smaller population, pre-existing cancer support groups and organizations, a newly expanded cancer coalition. We're still recruiting new members, so if you're interested, let me know. VI Cancer Registry, caring community leaders, and of course, our collaboration with the American Cancer Society. Some major cancer control challenges to consider is consistency and implementation, a lack of updated cancer incidence data, lack of adequate cancer specialists and facilities, better public and community cancer prevention education, insurance reimbursements and lack of access to treatment options, inconsistent palliative care and support services. Top 3 issues that I asked if we want to see addressed in the plan: financial assistance for travel, for medications and treatment options, and of course preventative screenings and diagnostics. The factors that influence cancer disparities: all of you who participated selected all of the choices, which are socioeconomic factors, inequities in healthcare coverage, access to care, poverty, and disability status. So what are some cancer support services we currently have? Of course, we have the Cancer Support VI. We have the Yvonne A. Galibert, sorry if I pronounced it wrong, or the YAG Foundation, American Cancer Society, chemotherapy, and of course, cancer-related counseling and therapy. Some ways to increase stakeholders' confidence to act on issues of health equity: utilizing cancer support groups and organizations, advocacy, education, and stakeholder trainings, more media opportunities for discussion, for example, like our summit today, some forums, and some more conferences. Proper health disparities education, community education and outreach, and increasing funding opportunities. So what would an ideal cancer plan relevant to us here in the USVI look like? Cancer support services, for example, cancer treatment and cancer care. Having a well-funded cancer coalition addresses all the social determinants of health related to cancer, provider access, increased cancer prevention education, access to preventative screenings, and we now have the patient's resource guides on your table, so a local resource guide for cancer services, and our updated cancer registry. Thank you guys for listening. If you have any questions, our information is on the screen. And also, if you would like, we can send you the presentation for you to look at yourself. Just let me know.
Thank you, Letitia. And I also have to thank our Griffiths coordinator, Mr. John Orr, who provided all of the data. He's always willing and available. He could not be here with us today. Any questions? Somebody's going to. I don't think people on the live stream can hear without the mic, so can you take this mic to her?
Hello? Oh, yes. Good morning. I just had a question and a concern as a GYN who thought that she had papped everybody on St. Thomas at least 10 times in the last 18 years at the low numbers there. And I noticed that, and I'm making excuses now, that there were lots of qualifiers to the questions on colon cancer about, you know, this is exactly what this is. And I was wondering if how is the question asked to the patients in regard to cervical cancer screening, because I know everybody thinks they've had a pap smear. I'm not convinced that most of my patients would say yes if they've had cervical cancer screening, which I know it, so I know now that I need to do better.
So there were questions on the survey specific to HPV testing and pap testing, but I would really have bored you out. I had them all in the presentation and I scaled back, so I can share data, additional data with you after. So I don't remember exactly what that data was for pap. You have it? We don't have the percentages, but see, it's on our computer, so we can get that to you.
Okay.
But yes,
I hope
so
it's
we do
better.
have that data specific for PAP, specific for HPV testing, but the one I shared was just cervical cancer screening in general. Maybe I should have decided to share PAP. Any other questions?
A couple. Do we have any idea who other is?
In the race, American Indian, Asian, Alaskan
Okay.
Native, yes, Pacific Islanders.
Here?
So yes.
Okay.
And then people who decided not to respond as well.
And I was surprised that looking at the different race and ethnicities, that the white responses were low.
I was surprised as well.
Because you're doing a percentage of those who responded.
Right, but they're representative. So the data is weighted. So they are representative. When we submit
Right.
it, yeah, so I was surprised as well. So this data is very new. It was released less than a month ago, but I did my best to gather it, to share it with you. We have not had a chance to do any analysis or come up with any theories, and I'm hoping that we can use this summit as a forum to start building
Okay.
theories and why we
Yeah.
could think this is the type of data that we are seeing.
And in some, Hispanics are low, and in others, they're high.
Yeah.
I mean, yeah.
It's
there's a
hard to
lot
predict.
There's a lot to parse, to go through and figure out why it comes out that way.
No specific questions. I just really want to congratulate you. We've been asking for data, so yeah, we have to do a lot of analysis on this data, but the data is here, and that is actually awesome. So thank you for all the work that you've done.
Thank you. So this concludes our live streaming portion. So I'm going to say goodbye for now to those of you on live stream. But please do join us tomorrow at 9 a.m. for the continuation. So the folks in the room now are going to move into breakout groups and where they're actually giving input, and we'll be recording on forums and then sharing back with the larger group. So they're going to be doing the work. If you want to comment on Facebook, please do comment. We have someone monitoring the Facebook chat, and we'll be taking all of your comments and input into consideration when we develop the plan. So
if I may, I've also spoken with our Director of Communication, Christine Lett, who is in the room somewhere, to see if we can actually post something on part of our website so that we could get more information from the general public as well. So that's something that we're going to be working on.
Okay, we are now a little behind, but we have a 15-minute break. I don't want to deny you of that break, but our breaks are going to be fun breaks. If you really need to get up and use the restroom or take a break, feel free to do so. However, I'm going to ask Ms. Monique. Monique is the program manager for the Breast and Cervical Cancer Early Detection Program. She has her work cut out for her, but I know she's willing, and she's very new as well, 4 months in this position. She's been with the Department of Health 26 years and very new to this role. So we're about promotion and in the Department of Health. And she has a little trivia game to share with you and some prizes.
Good morning again.